All right, folks, we're back. I'm your host, BKP. We're at Circuit World in Blue Ridge this morning. We're anticipating a little rain. I think I was listening to a pretty nice rain come through at 5 o'clock this morning. But so we move over here just to get out of the weather, and we're going to have a lot of rain in North Georgia. But it is time for Ask the Doc with Dr. William Whaley. This is brought to you by the Georgia Cancer Research Center, affiliated with Northside Hospital. Dr. Whaley, how are you?
Great, and my wife doesn't have to be out in the backyard the next couple of days with the little thing trying to get her seedlings to come up, because our 10-day drought's over with for a while.
Well, I'm glad you said that, because we need the rain.
Yeah, we're actually at average rain for the year.
Right, we need the rain.
A lot of rain, then we had this big period without rain. Well, we're not here to talk about rain.
I never
We're here to talk about
wait a minute. I never know with you, because you do give us the update. That's right.
Yeah, we're exactly on the average for the year.
Let's talk about that red, white, and blue tie for just a second.
All right. Well, I'm older than you by about 30 years.
Okay.
And my father was an FBI agent and a counter spy during World War II, and I have really spent a lot of time I've been to Normandy 7 or 8 times. About 15 years ago, I had an office manager who was a South African woman, and her father was a German veteran of World War II who fled to South Africa in August of 1945, meaning he was a Nazi fleeing out of the country. And he was an executive with Siemens. And as you know, many, many Nazis got engineering jobs all over the world, including in the United States. And every year they celebrated Hitler's birthday in their home in South Africa. And he died in his early 90s. He's only been dead a few years. So I have seen this small group of people in Germany who continued to think about National Socialism being a good thing. And this particular 75th anniversary of D-Day, last year I actually commented that nothing's happening around here to celebrate D-Day. In Germany, the big celebration this time was that the American, Canadian, English troops liberated Germany from the National Socialists. That phrase, I'm 79 years old, I've never heard the phrase uttered that Germany was liberated in any way by the invasion at Normandy. It's been the Nazis were defeated or anything else. So I think it's really a sort of a seminal change in direction for the German people, that was the biggest manner in which the German people spoke of the D-Day celebrations. And Angela Merkel, but not only Angela Merkel, but big newspapers and small newspapers and people on the street, that the Americans, primarily the Americans they actually said, but the Americans, Canadians, and English liberated Germany from National Socialism.
No, I get where you're going with that, because we discuss liberating France, and we look
defeating Germany
and defeating Germany, right?
Germany.
Exactly,
right.
But actually, I see where you're going. I got up, and I know we got to get to our questions, and I don't want to get all emotional, but I get up early, and with the time difference over there, the live ceremony started about 5:15 a.m.
Yeah.
And yesterday morning I watched it live, and I don't want to say negative, but when it comes to the French President Macron, I don't say a lot of very positive things. But yesterday morning, his speech, very good.
Yeah, and English.
When he turned,
he was in English.
When he turned and he looked at our veterans and bestowed the highest French honor on them and said thank you to them, I was taken by our president's speech.
Yeah,
I will say when Macron looked at our veterans and said thank you, I was telling you, yesterday was, and I got to watch it live, and I enjoyed it. I enjoyed it, and I thought it was.
I think our president really between what he did in England in 4 days and what he did in France. I'm not sure I've figured out about Ireland yet, but I think he really solidified this greatest generation sort of warmth. The Canadians weren't there. I didn't see the Canadians there, but the English and the Americans were hugging each other. And then the presidents of France and England were hugging each other. And I didn't have much use for France since they wouldn't let us fly over and bomb Syria.
I got it.
So I feel better today about the French than I have in 30 years. When did we bomb Syria? 30 years ago?
Well, you know, these guys, and I know we got to get to medical questions, but these guys are in their 90s.
Yeah.
They're in their 90s. And I tell you what I said to people yesterday on my show. If you see someone wearing their World War II if you see a 90-year-old.
We saw Dyer at the thing last week.
If you see a 90-year-old World War II veteran, I don't care if you're late for work. I don't care if you're late for school. I don't care what you're...
Don't be late to the doctor's appointment.
No, wait a minute. I don't care what you're late for. I don't care what a big rush you're in. You can't be any of that if that individual would not have done what they did. Stop and say thank you. Yeah. That'll take a second. But anyhow, this guy, I watched the interview. They were interviewing some, and you know, these are kids. They're 18, 19 years old. And he said, it was funny as could be because he was in the 90s. He said, a bullet flew right past my ear. And he went like that, and he said, that's when I realized they wanted to kill me. I thought he was great. How
about those guys that did the tandem jumps?
Absolutely.
What they're like 20 or 30 of them. I don't remember exactly how many, but they made tandem jumps back into Normandy. I was just absolutely. The first tandem jump was old President Bush. Remember, he was 90 years old, I think. And these guys were in their 90s making tandem jumps.
Well, this is a perfect morning, and you're the right guy to talk about it. And I appreciate our time, but we got to get to our question
today.
All right. Again, we want to thank Georgia Cancer Research Center, affiliated with Northside Hospital, for our segment, and we'll go into number 2. Cancer treatments have come so far and have improved vastly over the years. Can you tell us how has treatment for breast cancer improved in the last 10 or 5 years?
Okay.
What is the improvement there?
Well, you've heard me say a lot of things about genetics. I'm going to try and touch every part of the cancer spectrum here in breast cancer. The first thing that Josh has got up there is the idea, people have heard about the BRCA gene, genetic testing for breast cancer susceptibility, and I'm going to be going kind of fast here. But the picture that he's showing there, people who there are 2 different genes, BRCA1 and BRCA2. Women who inherit this gene will have a 45 to 65% chance of getting breast cancer, they don't even mention ovarian cancer, by age 70. And that is a huge number. So where that test has been done in somebody's family because their great aunt or their cousin or whatever had breast cancer, and you have this gene, then you should immediately be into genetic counseling in a cancer center where they may discuss with you at an early stage removing your breasts or getting you on a breast cancer prevention program or removing your ovaries or getting you on an ovarian cancer prevention program. So we'll start first with genetic susceptibility. That's all brand new in the last decade or so, and it's a big deal. All right, let's go to that second one. That's the bar graph. Now, you don't have to be able to read this thing, but just basically the high number is the people who have the BRCA gene, and the low number down there is the people who don't have the BRCA gene. And you'll see that breast cancer by age 70 is up to 87% here, and a second breast cancer, if you've had the first, is up to 65% if you have the BRCA gene. So now we're getting from the point that I'm worried about having breast cancer. If the BRCA gene, I'm going to go get genetic testing. Now we've just got your wife or my wife, and she wants to have the appropriate diagnostic procedures done at the appropriate interval to detect cancer of the breast. So show that next one there that's got those 3 women in it. The triple test for breast cancer is a woman over age 40 should be having a mammogram. That's the left lower picture there. At intervals, probably every 1 or 2 years, a woman in her reproductive years needs to be examined by a physician who is experienced in examining the breast, and that generally is going to be, there's a lot of family practitioners that never take off your shirt. So it needs to be somebody who takes off your shirt, takes off your brassiere, and examines your breast, and generally that could be your gynecologist. For most women, in communities where they don't have big gynecologic practices, it has to be a family practitioner or an internist. But a woman ought to make certain that she's getting her breast examined at certain intervals. And as I have said many times before, if you have, your right hand should look like your left hand on the mirror image. You remember that one?
Yeah.
All right. So if either by that exam or by the mammogram, there's a spot in one breast that's not present in the other, and it does not look malignant, you still have to do something to it. Now, if it looks malignant, you daggum know you're going to go get biopsied or whatever, but you got to do something to that breast, that lump. You've either got to aspirate it because it's a cyst or biopsy it because 20% of cancer of the breast does not look malignant on mammography. So that's basically what is new in the last decade or so about diagnosis is early diagnosis of the asymmetrical mass that is not malignant by mammography. All right, so let's go to the next one. People have heard me, you got the breasts up there okay. People have heard me talk about limited surgery to preserve the breast. That has been 30, 40 years. This is a picture of a breast biopsy taking out a small tumor, and you said probe right there?
Yes.
Okay, so what they've done here is they've injected a radioactive material into the skin that'll be picked up and go to the lymph nodes, and that probe right there will pick up the radioactivity. Now there's another picture, and it's just not as pretty, so I didn't bring it, where what they do here is where the breast cancer was, they put a blue dye, and the blue ink goes up there, and you don't need a probe, you can see it with your eyes. But the picture wasn't so pretty, so I brought the one that's radioactive. Actually, most of them nowadays are done by dye. So the advance is you don't have to take off the breast, you don't have to take off too much breast tissue in the breast itself, and you don't have to see how many lymph nodes are there?
Yes.
There's 30 lymph nodes there. You don't need to take out all 30 lymph nodes, which you used to do. You just need to take out number 1 or 2 or 1, 2, and 3, the ones that immediately get the dye, because if the cancer is going to spread, it's going to be in that lymph node with the dye. All right, now go to the next one. So in terms of modern breast cancer treatment, we now have done the biopsy, okay? We have a relatively controlled tumor, let's say that's as big as a plum. It may have one lymph node or no lymph nodes present. Historically, that patient, if the tumor was as big as 2 centimeters, or if it involved one lymph node, they were committed to take chemotherapy. Well, we have learned that there are people that do not have to have chemotherapy, even though the tumor is the size that historically was benefited by chemotherapy, because a proportion of the patient with a fairly good sized tumor and a positive lymph node have a low incidence of recurrence due to their genetic profiling. So you got the 70 gene test sign up there, Josh? All right, so there are 2 or 3 different profiles. I happen to pull up the one that's got 70 genes here. There's one that's got 20 genes. All right, so go to this next picture of these women standing here. Now, BKP, I don't want to confuse you here, but
that could be that's very
might be
easy.
easier.
Some days that's
okay,
very easy.
All right. 73% of all breast cancer patients have a positive hormone And you remember me talking about the HER2 gene
Yes.
that used to be a bad prognostic sign, and now we have a monoclonal antibody, so we actually can improve your survival. So 73% of breast cancers, if you were HER2 negative and HER2 positive, and the tumor was relatively big with the lymph node, there are a portion of that you may not have to treat. So those people are going to go off and get a gene profile. All right, now this next group, which is 13%, they have negative hormones. They are HER2 negative, triple negative. That's about as bad as you can get. That's wildfire cancer. But we do a great job with it because we are aggressive about chemotherapy, even with a small tumor. So they're not in the group that doesn't have to get treated. People that are HER2 positive and hormone positive and HER2 positive, they actually do quite well with the combined treatment of the monoclonal antibody and hormones. No chemotherapy at all. So what's new is fewer and fewer people are requiring chemotherapy because they have these markers. Now, only 5% of breast cancers are HER2 positive and hormone negative. But again, that group of patients quite frequently can get by without chemotherapy. So we go into our second bar graph. That 70 gene profile can divide you then into three groups. A low risk group where your chances of having a recurrence without treatment, hormonal treatment or anything, is only 6.8%. Well, you don't want to give big time chemotherapy to somebody who's got less than a 7% chance of recurrence. That means that 93% of the people that got that tumor would be getting chemo they don't need, right?
Right.
The group that's in intermediate risk, and this depends really then upon your age and the patient's attitude, it's only about a 14 or 15% recurrence rate. So you have to sort of balance those patients about yes or no on chemo, and if it's yes on chemo, you want to give them less aggressive chemo. But if you fall in this high-risk group and you got a 30% chance of recurrence, that's like playing Russian roulette with 2 bullets in a 6-shot gun. That group of people you want to treat with chemotherapy. So what's new then that is I haven't said a word about additional big-time surgery or radiation at this point. Just gene profiling, helping choose the exact treatment that is appropriate for you. And we call that individualized medicine. Remember, that's all over everything. All right, so the last one I want to show is kind of a complicated picture of one lump here.
Right.
And radiation. So this is just, I want to say a little bit about radiation. So we've said that we can give less surgery. Many people will get by without having to have chemotherapy. So surgery, chemotherapy, the third thing people talk about in treatment of cancer is radiation therapy. Well, radiation therapy has also made great strides in the last few decades because of physics and computers and the ability to target some tiny little place with high doses of radiation, which kill a bunch of tumor, and then by moving the light around or the machine around like that and focusing it on this spot, it frees everything else it goes through and keeps those things from getting damaged. So many people who have a lumpectomy to preserve the breast will require radiation therapy to the breast, along with the hormones, the genetic treatment, the HER2 new treatment, and the surgery. And they'll say, well, if I had my lump taken out, my lymph nodes taken out, and I got hormonal therapy, why do I need radiation? You still with me?
Mm-hmm.
All right. Well, the object is to conserve the breast. And if you have invasive breast cancer, positive lymph node, treated with the chemo and hormones, and do not radiate the breast, then the recurrence rate in the breast is much higher than we would accept. And then radiation that's easy to deliver, doesn't give you substantial side effects because of all that computer stuff is then added at the end, we would consider to be a mop-up type of treatment. So that's the last of the big changes that have occurred in the last decade, is all this computer-generated, physics-dominated, and that's way past my sandbox. But we've got experts up in Blairsville and down in Canton that can do it. So each part of the puzzle, genetic risk, I've got a really high risk, diagnostic procedures with the mammography and the biopsies, surgery with sentinel lymph nodes, genetic profiling with individualized treatment, and then lastly radiation. All of those have made great strides. Is that enough about breast cancer? Is that enough about breast cancer?
That's enough about that. That's enough about that. Georgia Cancer Research Center.
That was a great question they gave. But by the way, they're 5-day conferences that are 9 hours a day just on that topic. So anybody try to do that in 20 minutes, kind of hard.
Well, you pushed a lot into the 20 minutes, but it was great information, and we appreciate you very much for that. And we thank you for these great questions. And also, again, Georgia Cancer Research Center, affiliated with Northside Hospital. If you have a question for Dr. Whaley, send it to us, info, I-N-F-O, at fetchernews.com. Put in the subject line, Ask the Doc, and we'll get it over to Dr. Whaley. Our second question, and I find this second question interesting because it's just the other day I was watching TV, and this is one of those that they are burning up the TV with this. And
there must be some profit in it, huh?
Well, when I looked at this question, I said, wow, somebody else is out there seeing this commercial 90 times a day, all jokes aside. I am a 43-year-old woman, and I struggle with migraines. I have been seeing the commercial for Botox for migraine relief, and I want to know if this really can help me. I have used Imitrex and over-the-counter medication, but I still haven't found much relief. Great. I'm going to say great question because I want to know. I thought Botox was something else, but we'll get past that.
All right. I'm going to ask you if you can define for me what a migraine is.
No. That's a quick. I don't think I've ever had one. I've had a bad headache, but I don't think I've ever had one. I have to say no very quickly.
Okay, that's basically got the first one up there for me, Josh. Can you define migraine without reading the slide? Okay. Unfortunately, many people consider a really bad headache to be a migraine. There are many types of headaches that are not migraines that are serious and debilitating where people can't work. So the classic of a migraine is, one, generally there is a prodrome before the headache occurs that can last for a day or two. Go to that next slide. Let's go stay with that one just a minute. Other types of headaches, the most common type of headache is a tension headache.
I've had all three of these.
Okay. Tension headache, which is generally a band around the head, because a migraine is going to be on one side only. Okay? If you look at that, it's on one side only. A cluster headache generally is a migraine type, but it's round behind the eye. It's also...
Well, I've said, and I don't mean to be rude, I've said, well, I've got a headache in my eye.
That's it. Okay, that's cluster.
But not... okay. So I've had all three. I didn't mean to interrupt.
Okay, but muscle contraction tension headache is the most common.
Right.
And when it's really severe and puts you down, frequently the doc or the ER doc will say, you got a migraine, they'll give them a shot of something, give them a pain pill and send them home. A migraine is generally going to be diagnosed by a neurologist or an internist with a particular interest and expertise in headache. And let's go to the next one now. It's going to have, I'll tell you, I've had one migraine in my life and it put me in the hospital. My mother has a lot of migraines. Okay. Generally there is a prodrome of 1 or 2 days, which is those are just non-specific viral-like symptoms, irritability, fatigue. There is generally an aura. Most commonly, the one they describe is seeing waves of light that do like dark waves like that in your vision, one of your expert panel, when they have a migraine, has a big black spot in the vision, so that if you looked at that TV set right there that was turned on, you'd see a lot of the TV, and then right slap in the middle be a big black spot. Another one can be numbness or tingling around the face, inability to speak. That's the aura. That lasts about 10 to 30 minutes. What's happening then is the artery within the brain is going into a spasm like this and depriving a portion of the occipital cortex of blood. That then begins to go away, and the headache, which is when the artery dilates, begins to pound like crazy. That's each heartbeat, because what happens is an artery goes into spasm. You get this decreased blood flow in the brain somewhere that you see either as spots or whatever. Then it dilates and pounds with the heartbeat, and that's where the drug Imitrex and so forth are given. So there are medications to take at the prodrome to prevent it, which this patient does not mention. There are medications that constrict the artery once the prodrome is, that can stabilize the artery, and then once it starts dilating, it used to be that caffeine and ergotamine, which constrict arteries and can cause you to have angina or something else, were given to bring the artery back down. Imitrex is just a more specific drug. Now, what this patient does not tell you here is how many headaches do they have a month? Are they under care of a neurologist? Have they had prodromal treatment, preventative treatment? But next to the Botox, show the Botox picture. Yes, indeed, there is Botox is available for migraines, but if you look real carefully, they don't tell you this on the TV. Botox injected to prevent headaches with chronic migraine must have 15 or more headaches a month. 15 or more of these headaches a month. Well, the average frequency of migraines is 1 to 3 a year, not 15 a month. And listening to this patient, I don't think that they've had 15 a month. So that TV ad,
15 migraines a month seemed like it would be like debilitating. You couldn't function.
You can't function. That's right. All right, so the drug is approved, and it's 15 or more days a month with a headache lasting 4 or more hours each day. Well, that ain't way going to work 15 days a month if you're in bed with a migraine 4 hours or more each day, right? Plus, you got to be over 18, and you got to have a positive wallet biopsy and be able to pay the bill.
Positive wallet biopsy.
Yeah, right. So, yes. Prevention without meeting all of those criteria, 15 or more per month, 4 hours or more per event, and that'll have to be documented by a neurologist. So you can't get some family practitioner or chiropractor to say, hey, go get Botox for your migraine. So yes, there is a role, but I would tell that patient, because what it gets me is I struggle with migraines. And struggling with migraines is a miserable way to live. And I would say get your family practitioner to refer you to a neurologist. Let the neurologist confirm that you are having migraines and not repeated muscle contraction tension headaches. And then you come up with a very coordinated plan of prevention. There are preventive medications. There are abortive medications to take during the aura. And then there are drugs that you can take when that migraine hits you. So my advice to the patient there is, if you're struggling, that says it's interfering with the quality of your life, see a neurologist.
Well, and when I say that's enough for me, because I've been watching it on TV, it's seeing the commercials, and I want to thank you out there for sending that question, because when I say use for, That's up to the individual, but hear there's different uses for Botox that you personally want to use. But when it started telling me migraine, I thought, that's something you got to check out.
Yeah, I had a patient yesterday, by the way, who has vocal cord paralysis related to cancer treatment, who could not speak, who has had Botox injected into the vocal cord, and now can speak. I got another patient who had a motility discomfort with the esophagus and was unable to appropriately swallow and was losing weight, who went down to the specialty center and had Botox injected into the esophagus and now can eat. So Botox, rather than cosmetic, has many beneficial medical effects. Making the wrinkles go away on your face is fine, but if it makes the wrinkle go away on your vocal cord and you can speak, or the wrinkle go away in your esophagus and you can swallow, then Botox really is a valuable medical tool separate from its cosmetic effect.
Definitely some benefits there. Okay, well, at this time, what's new?
Okay, I got a couple
what's happening? Okay. What's developed?
I got a couple of quick things. We had another listener, I was going to say, send in a question about numbness in the legs, which we elected not to answer, and the staff are sending them the link to the last time we answered that question.
Okay.
I just want people to know that if you send the question, we don't answer it, and then you get an email back from the staff telling you to go to such and such a YouTube, it's been discussed before. All right, here's you can throw that up if you want, Josh, if it's not going to get too much. The very top news article last night was...
The last time America saw this many... measles outbreak, 1,000 cases,
yeah.
CDC.
All right, the last time America had that many cases was 1992. All right, that's back before we'd eradicated measles. And we're getting deaths now. So it's not a joke. And I keep coming back to the people that are sitting back over there behind me about the immunizations. The measles things have got to get taken care of. All right, and the last one here, this is for you, BKP. What's that say right there?
Balloons, pills, sleeves, weight loss options,
weight loss options grow. Everybody wants a B12 shot to make them feel young and sexy, or they want some pill to make them lose 30 pounds or whatever. So there's a huge profit motive in different surgical procedures, or putting a balloon in your stomach or a band around your stomach to help people lose weight. And 6 different balloon products that go in through an endoscope and go into your stomach will be hitting the medical market in the next few months to a year. They all are 10 grand or so a crack. They all have multiple side effects, and they all are successful in losing 5 to 7% of your body weight. Whereas the gastric bypass, generally you would lose 18 to 20% of your body weight. But they all are linked to what other weight loss drugs say, an increase. They're more successful if you increase your exercise and if you alter your intake of carbohydrates and calories. So you're going to, just like that Botox ad, you're going to start seeing ads in the next few months or a year about these procedures. They're 10,000 to 15,000 a piece. They aren't paid for by insurance. And we have a lot of people in this community who've gone down to Mexico to have the sleeve put in. There's no quick fix for weight loss, and it still gets back to diet, exercise, carbohydrate restriction, and calories. And it's like that Botox ad for the migraines. I discourage its use without trying the other stuff first. Is that enough?
That's enough. I appreciate that. Folks, don't forget, One, we want to thank Georgia Cancer Research Center, affiliated with Northside Hospital, for this segment. As Dr. Whaley was mentioning earlier, if you will go to our YouTube channel, FYN TV, Fetch Your News, find the playlist Ask the Doc. We have done, I'm going to say maybe 100 episodes, maybe more, but we have answered so many questions. So we do understand you're going to bring questions that, hey, we will do them again, approach them from a different way, or if the doctor has your age, male, female, and details, he can really, drill down in the answer. But if you are looking for something specific, allergies, pollen, legs hurt, you can research our playlist, Ask the Doc, on our YouTube channel, and he answers so many things out there that you can go to now and share with your friends. So we just want to let you know that. But we want to hear your questions. We want to have your questions sent to us, info at fetchernews.com, and put in the subject line Ask the Doc. And also our social media. You see, if you're a member, if you've joined our Facebook page, Instagram, Twitter, whatever, Fetch Your News, you will see multiple times throughout the week a reminder about Ask the Doc. If you put a question on there, we will look at the social media, try to find it off there. So don't hesitate. Let us know. Thank you, Georgia Cancer Research Center, affiliated with Northside Hospital. Thank you, Dr. Whaley. I appreciate it. Thank you for your tie. Thank you for your service, okay? And we're going to be back with the All-Star panel. Now, Ricky's been in the Himalayas or climbing Mount Kilimanjaro. We don't know. He's been somewhere, right? But he is back. He is ready. Bruce has his folder, and I'm sure Jane's watched some YouTube videos. So if we put all that together, that's called the All-Star panel right after these messages.